So we're supposed to be talking about, this title is called Controversies in Trauma. I'm not sure how much controversy there is in this, but we'll go through the topics. Just remember, I didn't choose the topics. So we're going to go through this, and we're going to talk about things. The first one we're going to talk about is, what role does intoxication, i.e. altered mental status, play in the evaluation of the trauma patient? There are some astonishing articles that you just can't believe in this section. You just can't believe it. One of them actually says that alcohol doesn't alter your mental status. Okay? We're going to get to that article. So you have to say, wait a second. I remember when in I think my second year of my career, there was a guy who decided he was going to commit suicide. So he took 2 40 ounces of vodka, and I was in Quebec City at the time, and he was going to drive north out of Quebec City drinking the vodka because he figured, by the time I get drunk, I'll be in the Laurentians, which are a lot of ski hills, north of Quebec, I'll go off a cliff and I'll die. That was his plan. The problem was he drank his vodka too fast. He drank 80 ounces of vodka in 20 minutes. I'm sure I could drink 80 ounces of anything in 20 minutes. 80 ounces of vodka in 20 minutes. So what do you think happened to his alcohol level? So he hadn't gotten to the mountains yet. And his car sort of slowly rolled off into a green, grassy, knoll slope and came to a rest. He had no injuries. His GCS was 3, and he wasn't breathing. Okay? And his blood alcohol level was 14 times above the legal limit. He was intubated for 3 days. But apparently, alcohol doesn't change your mental status. Because that's what it says in these articles. So, question number 1. Can I know by looking at people if they're inebriated? And your answer is? No. Depending on how you define inebriation. There are lots of people who go into acute withdrawal with their level 3 times above the legal limit. So if they're not 4 times above the legal limit, they're not normal. Their mental function isn't normal. And they walk that tightrope, right? If I go below 3 times, I'm in acute withdrawal. If I go above 4.5, I'm not breathing. And they walk that line. So you can't always tell if someone is inebriated. The idea that you can distinguish altered mental status from alcohol from other causes? Well, yeah, if there's a focal deficit along with it, but if there's no focal deficit, of course you can't. Can I tell by my nose if they're inebriated? It is amazing how many doctors, when you read their notes, patient smells of alcohol. So, how many of you have been told by mistake, we'll call it by mistake, that for supper you had a glass of wine, but you were going to do the midnight shift? Then you slept for a couple hours and went to work, and patient said, have you been drinking? Because you had a glass 5 hours earlier. There's no alcohol detectable in your blood, but you still smell of it. So our noses aren't very good either. Can I wait for a drunk person to wake up to assess his head injury status? What do you say? You're all hypocrites. How many of you have a patient, male or female, who you see every week drunk in your emergency department? How many times have they come in without a head injury? They all have lacerations, they smacked their face, they were drunk. How many times do you CT them? You never CT them. Why? It's Fred. He's here every weekend. He gets hammered every weekend. And he's got another cut I gotta sew up. And he's gonna pee himself. And he's gonna puke. And he'll leave in the morning. How many of you have that patient? Because he gets around a lot. And you don't CT him every time. So the statement that the literature that we can't wait, that we always have to CT them if they have a sign of an injury and altered mental status, none of us really believes that. The problem I have, just like you have, is I don't know where the line falls. between Fred and someone in this room who's been drinking who has a head injury, who do I need to CT? Where does that line fall? It said, well, now I know you, and you still might get a subdural, but you're drinking all the time. I've only seen you a couple times this year drunk. You have never seen before. Which one do we CT? And the answer is, I personally don't have a clue. There isn't a visible cutoff for me to say, these ones I can ignore, these ones I can't ignore. The only way to be 100% safe is you CT them all. But in fact, we all know that that's not what we're going to do. So if one of you has a way to define that line to make it visible for me, please come and tell me. Or you want to tell us now, that's great. But I've had lots of years of practice, and I still haven't figured it out. And we have all seen those chronic subdurals. My favorite was last year. This gentleman comes in, and he had had a nosebleed for maybe 30 seconds. He was 82 years old. I'm sort of looking at the daughter thinking, yeah, it bled for 30 seconds. I'm not going to do anything. And do you have any questions, any other concerns? Well, she says, I don't even think it was worth mentioning. But 3 months ago, he stood up and hit the top of his head on the edge of the kitchen cupboards. Doesn't take any anticoagulants or Plavix or anything like that. And he hit his head. I'm sitting there thinking, because it's one of my brighter moments of my shift. Okay, my brain is actually functioning. I'm thinking, and I said, have you noticed any change in your dad? Just nothing at all. He's the same dad I've always known. And I'm thinking, that can't be true. Or she wouldn't have brought up the question. She's seen something different. She just doesn't consciously recognize there's a difference. But she wouldn't have asked the question otherwise, because lots of you have hit your head on the cupboards in your kitchen. And if I asked you, when did it happen? You don't have a clue when it happened. I don't know, last year sometime. So I said, I examined him, and he's absolutely normal neurologically. And because I actually believe in a physical exam, I did a fundoscopic exam. And he had papilledema. And he had a 2.5 centimeter shift in his midline from his subdural. That had been growing, 2.5 centimeters, had been growing for 3 months. So we missed them. So the question is, does alcohol prevent me or make me have to CT more people? If you are clearly nothing but what's the risk? I can't afford to miss anything. And again, we talked about this yesterday. What's your threshold for risk? The literature says the only way you can be sure is you CT every person who's drunk who's had a head injury. Okay? Because we all have had cases like that. I just can't tell you that I will ever do that, because I won't. But I just don't know. It's my gestalt that tells me where the line should be of who gets it and who doesn't get it. And so it's a problem. Number one, accuracy of our nose to detect alcohol intoxication. Well, that's kind of silly, but it was 84% sensitivity. And it was 87% specific. So when we were sure they were drunk, 13% of them weren't. Now, that's going to be a problem in Canada. This is my cannabinoids talk on Sunday. Because the distilleries are getting into bed with the cannabinoid companies, and they're going to be making infusions of THC with alcohol. So you can get hammered, stoned, and pass your sobriety test. Isn't that great? Because your alcohol level won't be high enough, but the addition of the THC will make you unable to function properly, but you'll still pass your drug test. The smart university students learned this a long time ago. What they learned was they bought 300 milligrams of phenytoin. You take 300 milligrams of phenytoin, and it takes you 2 beers to get hammered. How many of you learned that when you were in university? Gosh, you're a bunch of losers. Did you not? What did you do in university? You didn't go out and get drunk and find out all the ways you could get drunk. But you could take 300 milligrams of phenytoin, 2 beers, be absolutely hammered so you couldn't walk straight, and pass every sobriety test the police gave you. And it's a lot cheaper. Because you could buy the 300 milligrams of phenytoin for $6. That's what a beer costs in a restaurant or a bar. So for $6 and then 2 other beers, you're hammered instead of spending 30 or 40 bucks. As a college student, how could you not take that deal? Come on, you got to get up on the social mores around you people. Electronic medical record number 2, review ED patients presenting with altered mental status with presumed ETOH intoxication. This is a large study, 30,000 patients. Almost 2,000 who were presumed intoxicated had negative ethanol levels. That's not chump change. Okay, that's about 8%. Illicit substances were there in the majority because they were still intoxicated. It just wasn't alcohol. But 19% of the people who were negative ethanol levels had psychiatric histories. There were medical reasons, hypoglycemia, et cetera, and 9% trauma in 18. And of the people who had negative ethanol levels and the ones you thought were drunk, 10% were admitted because of their trauma. So there is a small subset who you think are intoxicated that aren't. So you know you've all heard about, in medical error discussions about premature closure. It's a bad medical error. This is premature closure. They look like they're drunk, they smell like they're drunk is premature closure. So be wary. And number 2 is in the article that says, be wary. Number 3, 283 adults presenting with a GCS of 14 or higher with objective evidence of head trauma and a concentration of alcohol of 80 millimeters per mole or higher, so legally drunk. 8% had a clinical significant injury. Neither Nexus nor the Canadian head rules were accurate enough, missing 4 and 7 of the head injuries. There's a caveat to that. None of the people they missed required any intervention. So again, it depends where you live. If you look at the US studies about head injuries, they are very clear that you have to pick up every head injury, no matter whether you're going to do anything about it or not. In Canada, the studies all say, we only really care about the head injuries that we're actually going to do something about. If you have a small hemorrhagic contusion in your temporal lobe and it's gone in 2 days, who cares? If you have a subdural I need to operate, well, I need to know that. So, 2 different countries, 2 very different viewpoints about what's important in head trauma. So you have to apply number 3 and decide, where do I live? What's the legal threshold? What's important? According to this study, in the people who had an alcohol level above the legal limit, the CT head rules of Nexus and the Canadian head CT rule didn't identify some of the people. Because alcohol affects your impairment, your judgment. Number 4, study that does not pass a sniff test. This is great. 1,000 patients with head injuries on multivariate analysis, the blood alcohol level was not an independent predictor of the GCS. Wow. I actually wrote in my notes, WTF, when I read this article. They actually wrote that in an article and it got accepted by an editor. I was an editor-in-chief of a journal for 11 years. I can tell you something. That sentence would have never been allowed in the article in a journal I was editing. You're going to put in an article that blood alcohol level was not an independent predictor of the level of consciousness of the patient. I mean, it's just like, are you kidding me? With the exception of the patients with the most severe head injuries, alcohol intoxication did not reduce the GCS by more than 1 point. What, is this a teetotaling study? Like, did no one drink? I can admit in my younger years that I can guarantee you that my GS dropped more than 1 point on more than one evening with alcohol. And yet, they actually write this in an article. So then they make the huge leap and say that clinical decisions can therefore should not be delayed if alcohol is involved. We can't wait for patients to wake up because it doesn't matter because alcohol doesn't affect your GCS anyway. So if your GCS is down, it's head injury and you need to CT them. Alcohol is irrelevant. Wow. How many of you believe that article? Okay, on we go. Evaluation of C-spine clearance by computed CT alone and intoxicated with blunt trauma. I think this one is something we need to get closer and closer to. How many of you in intoxicated patients with decreased level of consciousness keep the collar on even though they've been imaged? Some of you do. And I know in a lot of trauma centers, this is still de rigueur. This is still what you have to do. Because you can't assess them. And so they can have a neurologic deficit even though their CT shows there's no bony injury. So in a lot of trauma centers, they still believe that the collar has to stay on until they wake up. But that problem is there are well-documented cases of 3rd and 4th degree pressure sores at the base of the occiput from the C-collar because it was left on for 24 or 36 hours. Erosions down to the bone. You know what you should all do? This is something I did, I think, my 2nd year in practice. You'd have to do 2 or 3 things, and we won't talk about your personal private lives in this discussion. But you should get on a stretcher and have certain things done to you. You should have a C-collar on and be put on a backboard and be left there with the sides up for an hour. If you do that once to yourself, you will never, ever allow it to happen to a patient again. Within 5 minutes, you have at least 5 pressure points in your butt and your back and your shoulders that are screaming because of the backboard. Because you can't get off the backboard because you're tied down to the backboard, paranoia starts setting in because people leave you alone. Then have someone wheel you around the department because you can't see anything. Because all you can see is it's moving by and you can't see me because you're in this collar. 1 hour. You will never do it to a patient again. The other thing you need to do, and again, this has got nothing to do with your personal lives, you get put in 4-point restraints. I could tell you, because I did it, and the nurses walk away, because that's what we do, right? And you're in a room, and you can't help it. You can't move, and within 3 or 4 minutes, your mind says, what if they don't come back? And within 10 minutes, you start getting like kind of antsy and like, you say, maybe I should call out, but you've told them not to come back for an hour. Because that's what I did. And I can tell you that hour was one of the longest hours of my life. I was sure an hour was up, and the nurse said, no, it's only been 10 minutes. Think about these things. So, they said in this study, 44% of the patients were intoxicated. C-spine injury was 9.4%. The negative predictive value of CT scanning was 99.2% and 99.8% for unstable injuries. So the recommendation from this study is you do the CT, you've cleared them bony injuries. If they don't have a focal neurologic deficit, get them out of the collar. Just do it. All right, what are the issues surrounding the evaluation of the C-spine? I had a fascinating couple of courses I went to in Britain. There is a center there that is looking at trauma in the elderly to incredible detail. And they have dispelled some of the myths around risk of death to elderly. They have shown conclusively that the elderly die at the same percentage as the young when their ISS scores are the same. We used to think that, well, people of elderly died with lower ISS scores. They don't. They die at the same rate as the young. The problem is the presentation to get that ISS score. It takes a much lower impact to cause the injury. If I take one of the people who are in their 30s in this room and I have you fall down on your butt, you'll have a sore butt. I take an 85-year-old who falls down on their butt, what do they have? They have a compression fracture in their spine. So much lower energy to get the same to get a higher ISS score. But their morbidity and mortality is the same with that ISS score. The other thing is that the elderly, once they've had a lesser amount of energy to cause the trauma, take longer to present their clinical symptoms. So a subdural, they have atrophy, So their clinical manifestation takes longer. So what we have done is, because it takes longer for their clinical presentation and because their energy of impact required is lower, we blow them off. Well, you only fell down. You only did this. You have to change the way you think. And if you take a look at number 7, 2016, spinal fractures in older patients admitted after low-level falls, fall from their own height. Spinal fracture, so less than 3 feet, their own height. Spinal fracture was the only injury in 39%. Okay? And these people were admitted. Those with spinal fractures were older, more often women, and more commonly had a spinal cord injury. They state they had a lower ISS, but that's not possible. If you have a fractured spine and a spinal cord injury, your ISS score is the same whether you're 15, 55, or 85. It's the same degree of injury. So they said they had lower ISS, but they didn't. They had a spine injury, so they had the same scores. It's just that it takes less energy to get that. So the normal level of energy you think of in mechanism injury for someone in their 30s or 40s is not at all what you should be considering in the elderly. There's a comment here. Plain films of the adult cervical spine belong in the ash heap of history. How many believe that's true? How many people rely on x-rays of the C-spine? Rely. If you don't rely on them, then what's the point of using them?
Sometimes it's nice to have a cross to know that they got a jump.
So the question is, how many of you rely on C-spine x-rays? One person? So in other words, you do believe that they belong in the ash heap of history. So I wrote down here, so that means do we throw out both Nexus and the Canadian C-spine rules, which I wrote are the 2 best trauma studies ever done? Remember what Nexus and Canadian C-spine rules did? They told us who not to image, right? But that was, don't do an x-ray. It wasn't who needs a CT. We have no study that says these are the ones you don't CT. That study's never been done. There has also never been a study done to say this percentage of people have C-spine injuries with no evidence on a normal x-ray of their spine. We all agree that if I take a C-spine x-ray and there's something abnormal suggestive of trauma, the CT will usually show more injuries. We know that to be true. If I see a subluxation of C5, C6, there's almost certainly other injuries that I haven't seen that the CT will pick up, which is why they say the CT is more sensitive and much better than X-ray. But I've yet to ever see a study done that showed all these people with CTs have unstable injuries that were where there was an absolutely normal C-spine X-ray. I've yet to see that study done. And yet, we don't have a study to say, like we do with Nexus and the Canadian C-spine rule, who doesn't get an X-ray. We don't have a study to say who doesn't get a CT. And we've never shown that CT picks up things on an absolutely normal C-spine X-ray. So therefore, it becomes a question of convenience. I'm going to CT your head for whatever reason you have. Well, then fine, go ahead and CT the C-spine because the total time required extra is 3 seconds. And after that, reconstruction by CT software is what takes the time. But to actually CT your C-spine after you've asked for the head is 3 seconds on the table. So it doesn't make sense to take 20 minutes to do the x-rays. Just remember, since we started seeing CTs of the head and neck in trauma, the rate of thyroid cancer has gone up tenfold because of the imaging we're doing. That's not theoretical. That's now proven. Tenfold increase in the risk of thyroid cancer. There is always unintended consequences of decisions we make. Number 8 is like many other things. It shows plain film sensitivity varies from 36 to 87% in low-risk patients, whereas CTs maintain 100% sensitivity. And I agree with that. No one in this room denies that CT is more sensitive than X-ray. I don't yet know if it's sensitive, more sensitive than an X-ray when it's an absolutely normal X-ray that's been taken. What's really odd is that for children with similar operating characteristics and performances, we recommend the exact opposite. Whereas now in adults we're saying, do a CT, don't do an X-ray. In kids we're saying, don't do a CT, do an X-ray. But their sensitivities are the same. So we're not even being internally consistent. Why? Because we're worried about radiation to kids. Don't forget what the famous study did in the BMJ in 2005. That study showed when they used half the amount of radiation required for a head CT to get rid of craniopharyngiomas, half the amount of radiation in infants, there was a marked decrease in kids being able to graduate from high school and perform at a cognitive level equal to the average in society. There was a huge impact on cognitive function. We're not talking about cancer, we're talking about cognitive function. When I first saw that study, because I read it actually 2 weeks before it was published, because I was one of the reviewers for the BMJ at that time, I went and talked to my oncologists, pediatric oncologists. I said, have you seen this? They said, oh, we've known that for years. When we radiate kids with cancer, they all become less intelligent when their heads are involved. We watch their mental functions deteriorate over a 3-year period. We all know that's one of the consequences of radiation therapy to kids who have lymphoma or cancer in their head, that their intelligence level is going to drop and cognitive function is going to drop significantly over a 3-year period. We know that. We've known that for years. We tell all the parents that before we do the radiation therapy. And we as emergency physicians had no clue that was true. You should now know it's all true, and it's one of the reasons you'd be telling the parents why you're not going to CT their kid's head. Well, we want your kid graduating from high school. Although looking at you. So, what else? Despite everyone telling us that CT is 100% sensitive for bony injuries, please remember it is not the gold standard. Why? Because it doesn't pick up ligamentous injuries. It doesn't pick up sclera, right? Spinal cord injury without radiological abnormality, that includes even if the CT is normal. So if you have someone who has an obvious deficit, you don't care what their CT shows, they need an MRI. If you have someone who has a stinger and gets clear, a football player who got clear burning pain down, going right down to both hands in his arms, he needs an MRI. It doesn't matter what the X-ray looks like, because I can tell you most football players have normal CTs when they get stingers. And they're the ones, when they get stingers, who are at risk for sclera, because they've ruptured the ligament to get the compression, and then they go out and practice, and 3 days later when they're practicing, they tackle somebody and they're paralyzed. So the football player who gets bilateral stingers gets an MRI, period, no matter what you find on exam. Number 11, CT scans were falsely negative for significant C-spine injury in 3 patients of those who had C-spine injuries. We know this is true. It's inherent that they be in places where they can get the MRI. Finally, to finish up, what are the issues surrounding the use of pan scan in the trauma? How many of you work in centers that do pan scans? So they should be going the way of the dodo. There was a great quote in a Journal of Trauma many years ago, where they said the pan scans are the way to go. We picked up on so many unidentified injuries that you have to pan scan them. And there was a comment, because there was discussion, and there was a comment that said, so in all of these, how are there so many unidentified fractures and unsuspected fractures? The answer was because we didn't examine our patients. They were brought into a trauma center and just sent for pan scan. And then they came back. Oh my gosh, look at that, they have a tibia fracture. We didn't think they had a tibia fracture. Well, that's because you didn't look at them. You just follow the protocol. Meta-analysis, pan scans when compared with selective CT trauma were associated possibly with reduced risk of death. However, number 15 is probably the one that puts all this to bed. React 2 in a randomized trial. Imagine that, a randomized trial in trauma. Like, you almost have to take a pause. Wow. Mortality at all times, pan scans versus selective. Mortality times was the same 16% in-hospital mortality for both groups. And in fact, on secondary analysis, which I don't like, it's called data torturing, but it says something that I agree with, so I'll bring it up. Patients undergoing selective scanning had completed their imaging in less time, and the life-threatening diagnoses were made earlier. Now, let's be honest, we have to be fair. The difference in time was 7 minutes to have the testing done less, and 8 minutes faster to make the diagnosis.
How many times have you seen a trauma surgeon?
Hey, listen,
Some don't even carry a stethoscope.
I understand that. Neurosurgeons don't examine patients, they look at CTs. I understand that. So the last thing, because it's time for a break, what does it mean if a trauma victim poops themselves? We know very well what it means when the physician poops himself or herself, right? And the study said, there's actually a study about this. Sphincter incontinence is never a good thing in patient or professional. When your sphincter has tone that is not normal, it is a good reflection of how well you're performing at that moment in time. They actually did a study when involuntary defecation occurred in the trauma room, there is a high rate of mortality, especially with penetrating chest trauma. And then Al Sacchetti wrote, personal experience shows that when there is involuntary defecation by the provider, patient mortality is even higher. All right, take a break. We'll see each other in 15 minutes.